can start, sir.
Yeah, okay.
Good evening, everyone. Myself, Dr. Sunil Dadhich. I'm a professor of gastroenterology at SN Medical College, Jodhpur. I'm a governing council member of Indian Society of Gastroenterology. So, on behalf of Governing Council of Indian Society of Gastroenterology, I welcome you all to yet another series of lectures, Gastroenterology Session, organized by Global Association of Physicians of Indian Origin in collaboration with Indian Society of Gastroenterology, that is GAPIO-ISG International Lecture Series. Today we have two lectures by eminent speakers, and to chair the session we have a person, Dr. Mathew Philip. He is a senior gastroenterologist from Kerala. He is a Secretary General of Indian Society of Gastroenterology. He is a head of department of Leeds Institute of Medical Sciences in Kerala. He has n number of empty number of publications, chapters in the book, and above all, he's a very good human being. So I invite Dr. Mathew Philip to introduce the speakers and start the lectures. Thank you.
Thank you, Sunil, for your kind words. And I bring in greetings from Indian Society of Gastroenterology. And as you are aware that Indian Society of Gastroenterology is on the forefront of disseminating knowledge or science to the fellow gastroenterologists and as well as other physicians. And we have this GAPIO series of lecture, IST GAPIO series of lectures are mainly intended to physicians and also other doctors international of Indian origin. And today we actually select certain topics which is relevant to physicians or surgeons practice. And today we have two important speakers and talking on two important and rarely discussed diseases. So may I introduce Dr. Zubin Dev Sharma. Zubin is a consultant gastroenterologist at Institute of Digestive and Hepatobiliary Sciences at Medanta Medicity, Gurugram, Delhi. Zubin is clinical in charge of the neurogastroenterology and GI Motility lab at the institute. He did his DNB gastroenterology in 2016 and has secured All India Gold Medal, for which he was awarded by Honorary Vice President of India. He was also secured a gold medal in his MD. Zubin has more than 25 national and international publications to his credit, including book chapters and guidelines. Zubin is very keenly associated with the neuro gastroenterology and motility lab in the institute, and he's an upcoming star in gastroenterology. And very few people actually take up GI motility or luminal area. So I'm so happy and proud to introduce Dr. Zubin Dev Sharma. And after his talk, we will have Professor Usha Dutta, and I will introduce her during that time. And we are really fortunate to have these people. And Dr. Zubin is going to discuss a very important topic of dysphagia and how this should be evaluated and how we can come to a diagnosis. So I think it is very important. I may call upon Dr. Zubin to share his slides and start his lecture. And also request the participants to post their questions in the chat box. We'll try to answer the questions as and when it comes. After the talk is for 20 minutes and we have 10 minutes for discussion. Dr. Zubin.
Thank you so much, sir, for those kind words. It means a lot to hear all those words from you. And I am thankful to ISC and the Global Association for this platform available to talk on a very important topic, that is dysphagia. So when I was given this topic, I think it's very pertinent that we understand that dysphagia is not something that we as gastroenterologists would only see. It is something which is widespread all across all medical doctors. I think physicians, ENT persons, pulmonologists, even cardiologists to some extent would at some point of time understand or hear about dysphagia. So in next 20 minutes, what I will try to do is try to make it simple that how we can clinically examine the symptom of dysphagia. And now in the era of evidence-based medicine, what more we can do. We all been doing endoscopy, what extra we can do for it, and how do we can use those available testing to really manage our patients and not only prove a diagnosis. And as well as I will try to move into that what can be the future of further understanding our symptoms. So just in a very quickly way, I think more than one third of population, particularly elderly population, at some point of time would have this complaint of dysphagia. And as we go into subgroup of patients who have neurological illnesses, both stroke or neurodegenerative ones, and if you really look into the data, close to 80% of them at some point of time will have dysphagia. We today are able to do much more for them and try to understand their symptomatology by simple tests that are available to us. And just to this infographic is just to tell you that it's not a rare cause for a significant morbidity of these subgroup of patients. So, in a very brief way, as doctors, we want to fit everything into terminologies. We look at dysphagia, we look at odynophagia, or a globus sensation. So, quickly in an OPD, we try to fit our patients into this spectrum, whether you have a difficulty in swallowing or a painful swallowing, or everything is normally just have a feeling of something stuck. The problem is that within this spectrum, there is a significant overlap. Your patients will tell you a lot of different things, and all of these words you have to try to fit into our medical understanding of dysphagia, odynophagia, or a globus sensation. So with this slide, what I want to highlight is that your patient will not be able to fit themselves into this spectrum. We have to look at them as a whole, and we have to look what is the predominant symptom in their symptomatology, whether it is dysphagia, odynophagia, or just a foreign body sensation. That may help you, but you will see a lot of patients who have significant overlap. Now, after we have seen that there is a significant overlap, this is the that I usually follow in my practice. What I see is that I want to divide them into an oropharyngeal dysphagia or a neuromuscular dysphagia complex versus an esophageal dysphagia. And after every workup has been done, it's negative only, then I label them as functional dysphagia with the word which I don't usually like because it's a DGBI rather than just a functional word. But for our simple practice, I think we should understand an oropharyngeal. Now, oropharyngeal and neuromuscular dysphagia is something which are collectively called as a transfer dysphagia, whereas esophageal dysphagia, as we all are aware what we are talking about. Now let's go on it one by one. So oropharyngeal or neuromuscular dysphagia, or simply I would say transfer dysphagia, can have multiple reasons. In a very pure form, oropharyngeal dysphagia means difficulty in the initiation of your swallow movement, that you can't really initiate a swallow from your tongue. Whereas a neuromuscular one means that you can initiate it, but you can't push the food bolus down the pharynx into your food pipe. What it means is that you may have a problem at the muscle level, you may have a problem at the structure of the tongue level, it can be a structural problem at the level of arytenoids, or it can be some other local pathology. So dividing them into different causes, you can have a neurological diseases, both acute as well as chronic, or you may have a very important subset of patients like who have a structural things like Zenker's diverticulum or oropharyngeal tumors. Patients with systemic illnesses like Sjogren syndrome will have a decreased saliva and xerostomia. They will have difficulty in pushing it down. Patients with prior history of radiation head and neck syndromes will have radiation-induced changes. Radiation-induced changes, even if they are endoscopically normal, will still have a dysmotility. They won't have a normal push. And of course, post-surgical patients, total patients will have difficulties. So all this forms the transfer dysphagia. Now, if we talk of the neurological dysphagia, I usually like to divide them into a sudden onset one, which is usually a strokes, versus a gradual onset one, which are usually myopathies, or rarely they can be some kind of neuropathies. The problem comes is when dysphagia is the presenting symptom. When it's a presenting symptom, that's where, because you will not have any other neurological localization, it creates a problem. And I usually, like sometimes I see them with patients with lateral medullary syndromes. I've seen them with patients with the brainstem lesions who only present with dysphagia to begin with, but subsequently in the natural history, they will obviously present with other findings. Now, if you look into the causes, downstream, we have gone from the oropharynx to esophagus. Esophagus is a Pandora's box. You can have n number of causes. Now, how I divide them is I divide them into intrinsic and extrinsic causes. Intrinsic means something is wrong with the mucosa itself, and extrinsic means that something is impinging on that mucosa. And there's a very important category of motility disorders, where you are totally, dealing with a different subset who are endoscopically usually normal. But at here, I would like to say that even in motility disorders, you may have sometimes an intrinsic abnormality. For example, an eclasia can have a abnormal, mucosa, very bad mucosa, and causing a stricture. You can have a systemic sclerosis patients with severe GERD as well as stricture. So it's not that motility disorders cannot have intrinsic causes, it can still have. And intrinsic causes can be, I'll show you in the few slides, from strictures to foreign body, benign and as well as malignant strictures. It can be infective, particularly patients who are diabetics or use inhalers for COPD. They will usually have candida or other infectious esophagitis causes. So this is a very important subset of patients which may have intrinsic causes itself. Now, how do we approach this patient? History is, of course, something which is very, very important. It's something which will guide our investigations. So identify which have dysphagia or dinophagia or both. Now, more important thing is how is the onset? As I said in the neurological one, abrupt or gradual, consistent or intermittent. So if you have a patient who has an esophageal possible, dysphagia, which has been persistent and static, it is usually a benign stricture, versus a consistent but progressive, that can be mostly a malignant stricture. Solid or both solid and liquid. Now, there's usually a confusion that in motility that it's only to liquids. That's not the case. Very, very early, subgroup of patients, you may have only to liquids, but subsequently they will develop to both of them. And for solids, we are dealing with the structural lesions, of course. Look into associated features, change in void, choking sensation, halitosis, as well as past medical and surgical history. After you have done that, do a good examination. I think two important thing is when you inspect the oral cavity, look into the movements of the palate, how they're happening, and do a good detailed neurological examination. A lymph node examination of the neck and epigastric examination will give you a lot of findings. And rarely you can pick up a cardiac murmur causing these problems. Now, coming on to what all tests, all this list is available. And I'll go through one by one, trying to tell you how we can use them. Now, but question is how and where do we start? We need to have some guidance available to us that what test do we have to do. Coming on to that, I think in the history itself, it will be pretty clear that what we are dealing with. If it is oropharyngeal, you will have all these features: difficulty in initiation, drooling, food spillage, repeated swallows may be required by the patient to push it down, and you will definitely have some history of pre-existing illness. Versus an esophageal one, you may have a delay, you may have a painful deglutition, or you may have a sensation of something getting stuck. Now, localization of pathology in a patient who has dysphagia is usually, or is rarely correct, because they may start saying I have food getting stuck in at the center of chest or in the neck. It can happen in both the reasons, so we should not be using that as a criteria to see our investigations. And for solid and liquid, I've already mentioned in the previous slide. Now, this is the first thing. I think in a patient, when I think of an oropharyngeal or transfer dysphagia, this is a modified barium that you can do, and you can also really do a gastrographin swallow. You can easily identify the local structural causes, and you can pick up subtle motility causes and the risk of aspiration in patients who have oropharyngeal dysphagia. This is an age-old technique, but it is still very viable in today's time. Now, this is a very important video. I think this is something called as a flexible endoscopic evaluation of swallowing or fees. Now, this is useful in patients of neurological dysphagias or patients who are post-malignancies, post-radiation, post-head and neck surgeries, who come to you with dysphagia. You give them a food, you under endoscopic vision, you ask them to swallow, you examine the swallow, you look at the movements and you look at aspiration happening inside the lungs. In this patient, you can clearly see that there is some amount of asymmetry in aspiration, and the movements of the vocal cords are also hampered. You can see some amount of food liquid residue below. So this is a good examination which can be easily done on an OPD basis. This is something we do in our settings for patients who can't be moved around. We give them a food dye. We ask them to swallow. We just do a suctioning of the trachea, and if we see some dye inside that, we think that there is some aspiration, and this patient would continue to be on rise to feeding. They don't require any further testing. Now, after we have done this, rarely we require something called as a UES manometry or upper sphincter manometry. Now, this is something which has been like recently available in a lot of centers now. What you can do is you can pull up your catheter and look into the UES. If you see on the first image, that's a normal pharyngeal stripping swallow. But if you see in the image below, you can't see any pharyngeal contraction. So this was a case which had a brainstem lesion impinging on 9/10th nerve, and there was no other localization except dysphagia. And with the help, after that, of course, we did an MRI and we could pick up an abnormality. So UES manometry can sometimes tell you. One important thing it can also tell you is pick up local causes like cricopharyngeal eclasia, which can be endoscopically treated as well. Moving on. Now, this is we go to our gold standard of something like which we call as an endoscopy. Endoscopy is a must when we talk of evaluating esophageal dysphagia. This video predominantly shows an eclasia, a pop at the level of LES, but it can pick up not only this, but n number of more reasons. You can have an esophagitis, you can have eosinophilic esophagitis, food impactions, malignancies, reflux strictures. So I'm sure you all are aware that endoscopy is a must, and a nicely done endoscopy is a must for a basic evaluation of dysphagia. After an endoscopy, I still do my own gastrographin swallows or barium swallows. You can see in these two images, the first one is a DES or a diffuse esophageal spasm. The second one is an early eclasia. You can easily get it done in your own center or from your radiology, and I think it still has its place in evaluation of dysphagia. Now, coming on to, manometry is something which I enjoy doing a lot, and it has really changed the way we look at dysphagia. Now, this is a patient who was endoscopically negative or endoscopy was normal for his evaluation. He still had only chest pain while taking food. This chest pain was never severe, but he had some reading towards his left arm. He underwent a coronary angiography, which was normal. He came to us for evaluation. And you can clearly see that when he is taking swallows, you can see a contraction happening and you can visualize it. This contraction happening in this 3D reconstruction. You can show it to the patient and you can tell them that, yes, what kind of narrowing is taking place in their distal esophagus right at this point in the red area, and why the patient cannot eat. So this is now standard of care for evaluation for motility issues. And just in a very quick, brief way, we have three kinds of peristalsis in esophagus. For primary peristalsis, you do a manometry. For secondary peristalsis, you do something called an endoflip. And for tertiary peristalsis, you can do a gastrographin swallow. Now, manometry has moved on from just a diagnosis of eclasia to much, much more things. We are able to pick up DES, jackhammer esophagus. We are able to pick up systemic sclerosis. We are able to pick up early stricture formation. We are able to identify, a lot of swallowing issues by just doing an HREM. And I think a nicely done, properly done manometry is something which is extremely important. Like for this patient had dysphagia. We did a manometry. There was absent. There were no contractions in the food pipe at all. The LES was also hypotensive. We went ahead, put the hands inside the eyes, and you can see some very early, Raynaud's phenomena. Ultimately, the patient was diagnosed to be a sclerosis. So I think the manometry can help you not only in diagnosing eclasia, but many other things. In GERD, really, you will have patients who come with dysphagia. Now, you can see this is a 24-hour PF study. And on the right side, all that red and orange area is where your esophagus is exposed to a pH of around 2. So you can imagine the amount of harm this may be doing. So GERD patients also require something like this. This is an impedance manometry rather than simple manometry. Structural, obviously, you can have esophageal submucosal tumors, which may cause dysphagia. You can have vascular lesions like subclavian, aberrant subclavian artery, and EUS, and a CT imaging of your chest is very pertinent in this clinical setting if you have to do. An endoflip is something which has now come up. An endoflip is something which is done endoscopically. You put in a balloon which has sensors across the ileus, and you look into the distension and the response of esophagus to that distension. This response tells you whether the esophagus is able to relax completely or not when the food comes down from secondary peristalsis. So this is something which is now available in West as well as Europe. Soon will be launched in India, and we will have our Indian patients who can be benefited from it. Now we can combine multiple things together. You can combine a barium with a manometry. These are from our own, set of patients. You can look into the abnormalities while they are swallowing, both structurally as well as physiologically in a single setting. Moving on from this, I think I'll just wrap it up with the good algorithms. This is what I use in my practice. When you have a suspected oropharyngeal dysphagia, a specific diagnosis is there, you can do that. If it is a structural thing, you do a FEES or a nasopharyngoscopy. Otherwise, if it's a neuropathic, you can do a barium swallow, or you can combine them together. Then if you find something, you take a biopsy. If not, you can do a UES manometry, which we are now routinely doing to pick up either a 9th, 10th palsies, or we can pick up cricopharyngeal ecclesias where we can inject Botox in the level of a UES and try to relax them. Usually they will have some anatomical structures like you can have some diverticulums happening, but sometimes cricopharyngeal ecclesia can be a precursor for somebody developing diverticulum at the level of UES. For esophageal, it's a bit more complex. I think you can do an EGD upfront, or if you do not have any red flag signs, you can do a trial of PPIs. Otherwise, if they still don't respond, you can do an EGD. Red flags, we all are aware: weight loss, immunocompromised, lymph nodes, any masses. If there's a known pathology, you can go for a barium upfront or combining EGD with it. That's your choice. Further, if it's a biopsy required, you take it. If it's normal, you can still do a barium. But I personally usually do something as called as a manometry first rather than anything else. And you can do a chest imaging also if required. But everything is normal, then you label them as functional dysphagias. And so to conclude, I think dysphagia is a common presentation. Now the time has gone that from only on the basis of making a diagnosis only on history, we have to move on to an algorithmic based approach using all the available technologies depending on what kind of symptoms are there. We confirm what we think on history and examination, and finally we choose. For example, if you have a neurological patient with a abnormal fees, you can't put them on oral diet, versus you have a patient who has endoscopically negative dysphagia. Manometry will give you a lot of answers. So choose your investigation depending on what you see in the patient. That will decide your management. And in patients with ecclesia, in fact, manometers will also tell you how much and where to do your cutting. So, and just a single slide on the future, something is coming up called as, esophageal distension plots. Here, like practically you can, it's like a barium and a manometry together in a, color topographical way. It will show you how your swallow is going down like a barium, but it will also tell you how much pressures they are creating. So this will come, and thank you again for giving this opportunity. And this is our lab, and you all are welcome there. Thank you so much.
Thank you, Zubin, for this wonderful presentation. It was crisp and you covered everything. But I know that it is very difficult to cover such a big, vast topic in such a short time because, but we want to have an overview. There are some questions. I think, we can, again, I request all the participants who want to ask question, we can actually put across questions on that. And Sunil, you can also put across questions,
Yes.
ask questions. You can.
Yes, sir. Can I, Zubin, can I ask
Yes, sir.
your first question, which has been asked by Dr. Amit?
Yes.
What is the first investigation of choice whenever a person comes to you with dysphagia? You'll do barium or you'll do endoscopy.
So, depending on the symptoms, as I said, that I will clearly differentiate an oropharyngeal or a esophageal cause. If it's an esophageal cause, I usually do an EGD first, uh, until unless they are young and there is no other obvious clinical red flag signs. I may give a trial of PPIs, but in my practice, I do endoscopy first. Maybe because I'm a gastroenterologist, I prefer that. But I think EGD I still feel is the first choice.
So you'll
And
see the clinical setting. If the person has CV or other abnormalities, probably you will not do endoscopy first. Take it history in detail, and then decide whether he needs it or not. And then if the person
Yes, so
doesn't have,
history is
yes, so history is very important to decide which investigations to go for the first.
Subin, I
Isn't
think
it, Zubin?
Subin, I think the key step would be to find out whether it's a oropharyngeal dysphagia or transport dysphagia versus an esophageal dysphagia. I think that is the key thing, because when you are
that
working
is
on,
the most important step, sir. Yeah, yeah, that's the most important.
there is another question by Lal Krishna Unikrishna about how is the timed barium solo done and how important is that? And can you please tell about the procedure very briefly?
So time, yes. So timed barium swallow is a modification of the usual barium swallow that we do. It is more important in patients who have an suspected EJG outflow obstruction. That means eclasia or eclasia-like disorders.
Can we request to
In that
stop it, Luigi?
we usually give them thick barium, and we look into the height of the barium on the fluoro image or on the X-ray image at different intervals, 1 minute, 5 minutes, and sometimes even longer than that. And this height will correlate to that abnormality. Usually, we use this more often in a post-intervention setting. For example, if you have an eclasia, you've done a myotomy, and they still have symptoms, you can use a timed barium. But for purely diagnostic purposes, pre-intervention, I think a simple barium is also not bad.
And I think we can compare with the pre and post intervention. You have got
Yes,
it.
we can do it. So we can do a pre-post intervention comparison.
And I think when we are suspecting achalasia or easy outflow obstruction, we always request the radiologist to do a timed barium. That
Yes.
will be better. And another thing is that when will you actually refer a patient from your side to the ENT surgeon for evaluation of dysphagia?
So how I do most of my EGDs is that whenever I have a dysphagia, the first thing I do is I look at the vocal cords when I'm going in. And if the patient is awake, I'll ask them to try to speak. And if I pick up something there, if I pick up abnormal movements of the posterior pharyngeal wall or vocal cords, I'll quickly finish and I'll refer them. That usually happens. Sometimes, obviously, in the history itself, if I'm sitting in the OPD and I strongly feel that the patient is an oropharyngeal dysphagia, I would refer them to an ENT first for a local structural cause. But if the clinical setting tells me that it's an acute event or there is some relevant neurological background is there, I would refer them to a neurologist first rather than an ENT. So my choice of referral to ENT or neurology will depend on what kind of history they're giving me. And sometimes, as I said, on table on endoscopy, I'll pick up findings there.
And I think it's important to examine the oral cavity by the physician or the gastroenterologist as well, because it's very important to differentiate between a structural abnormality of the oropharynx like malignancy versus that happens to a neurological manifestation. So there is another question by Dr. Raj, is how do you manage a patient with diagnosis of myasthenia, experiencing dysphagia, but not responding to conventional treatment of myasthenia treatment? I think it goes the purview of a gastroenterologist, isn't it? What do you think?
Yeah, I think we need to have common ground with the neurologist in this patient, because at first I'll discuss with the neurologist that why that have they maximized their potential treatment of myasthenia. If they had and they still feel that patient is complaining, I will go ahead, and in these patients I will probably do either a barium or a manometry first. And in my own opinion, I'll do a manometry first. Why? Because it doesn't require sedation. My patient can be conscious. Endoscopy in myasthenia may be a bit tricky with all the sedation. On manometry, I will look at UVS also, and I'll try to find out any other abnormality which can coexist with myasthenia, something like LES issues. But if still that doesn't give me an answer, I would want to do an EGD to look for things like inside the esophagus malignancies or strictures. So I will go ahead and try to find other causes than myasthenia if somebody is not improving. But I will obviously talk to the neurologist first to be sure that they have maximized their treatment of myasthenia.
Sunil, I think you have posted a question.
Yes,
Why
sir.
don't you-
I think, Zubin, one of the common problem which physicians face in their day-to-day practice, the person who's having bronchial asthma, and they come to you with some kind of dysphagia. So how to approach to them, because they can have associated other disorders in the esophagus. They can have some complications of therapy which they are using. So for a
Yes, sir.
physician, how do you ask them to approach?
So the first thing of any COPD or asthma who comes with dysphagia, I think the commonest thing that I have seen is they are usually on inhalers, and when they are on inhalers and oral, inhaled steroid, there is a good chance of them developing something like a candidal esophagitis or oral candidiasis. That's one thing to look
Yes.
for, easily
Yes.
treatable. And
Mm.
then next subgroup of patient, next issues is usually they have an associated reflux disease sometimes, which uh, can be sometimes erosive and cause strictures. That's something we need to look at. Rarely, you can have something like an extrinsic compression on esophagus, but these things are extremely rare. The commonest thing that I see is candida and reflux disease if somebody had dysphagia with an underlying pulmonary issues.
Yes. So I think we need to tell them the correct way to use the inhalers and other issues. And then
Yeah.
if the person is having an allergic form of asthma, you can also think of eosinophilic
Yes,
involvement of
eosinophilic is
esophagus.
yes, yes,
Yes,
definitely. That would
that should
require
be
biopsies from
kept in your
esophagus.
mind. And yes.
I think, candidiasis, esophageal candidiasis is sometimes overlooked, especially in patients with poorly controlled diabetes, immunosuppressed patients, and all those patients who has, especially patients on steroid inhalations, on steroid therapy. When they come with dysphagia, I think, this needs to be looked in, and very eminently it can be treated as well. So examination of oral cavity for oral thrush is also important. So, Subin, one more last question is by Lal Krishna. Can we use Chicago classification for upper esophageal sphincter manometry? Is there any role of manometry?
No, we can't use Chicago for UES manometry. Chicago is purely meant for
Sure.
esophageal body disorders or LES disorders. UES has not been standardized. UES, we don't even know the normative values. As of now, what I practice is it's my visual impression of doing a UES manometries. I can't even provide pressure values to it, although I can calculate it, but whether it is significant in borderline cases that we don't know. So Chicago, no, we cannot use. We still need to create that data for normative values.
So is there any, there is a question by Dr. Piyush. What additional information do solid bolus give in manometry?
So solid bolus has a very particular role. I think now in Chicago 4, they do recommend using solid swallows for evaluation of borderline cases in patients who have significant ineffective motility to water swallows. I'll try to give them solid swallows to see if they have any underlying reserve for solid swallows, because the DCI will definitely go up once I give them solid swallows. Second subset is in patients who have a possible EJG outflow obstruction, which is not, which is just kind of covert and not becoming obvious on either changing the position or increasing your MRS or RDC. In those subgroup of patients, I will still give them a solid swallow and try to see whether that creates the EJG outflow. That's where the additional information can be given on a solid. But once again, solid bolus are not yet part of the Chicago protocol. They have been advised in Chicago, but not asked as being a mandatory part of Chicago, like MRS or RDC are now.
What is the solid swallow you do? What solid is
So
needed?
cookie swallow is a combination. What I do is the simplest thing is I use those 10 rupees biscuits that are available. I ask them to keep it in their mouth. Just do a chewing movement and don't swallow until I ask them to. Once it's kind of a slurry, I ask them to take it. Otherwise, you can use curd, you can use custard, usually soft things that can be easily swallowed.
And is there any
Okay.
concern? Question is by Srejal, and is there any concern for blocking of if you are using a water channel, water perfusion system when you use this?
No, not usually. So I have not. So see, water channel will get blocked from inside your catheter. Even if you give a properly chewed swallow, whether it's a curd or a custard or a biscuit, it usually doesn't create problem. You obviously are going to wash it immediately as soon as, because this is the last thing you're going to do towards the
Yeah.
end of manometry.
So I
So
think, we are running out of time. There is only last.
Mathew, can we proceed further?
Okay. And thank you so much, Zubin, for this wonderful presentation. I'm sure more questions are coming. If time permits, we'll ask questions at the end.
sure, sir.
So I have got great pleasure in inviting Dr. Usha Dutta. Dr. Usha Dutta is the head of Department of Gastroenterology in the Premier Institute of India, PGIMR, Postgraduate Institute of Medical Education and Research, Chandigarh. And she's a very important member and faculty of Indian Society of Gastroenterology, and she's an eminent teacher, and she's the chief editor of Indian Society of Gastroenterology, which is a very coveted post. And she's also in the editorial board of many other journals, and 2 international and 4 national journals. She has initiated many teaching programs in PGI Chandigarh, and she has initiated the so-called PGI AIMS SGPGI endoscopy, the e-Patashala, for trained postgraduates, to train postgraduates. It's actually, this program is a well appreciated and well attended program, and it introduces many endoscopic techniques in that. She also has started the national postgraduate programs on research methodology and GI emergencies. And she has mentored 40 MD, DM, and PhD students. And she is also in the advocacy of Indian government in Ayush. And she has large publication. She's excellent clinician, good human being, and also a great teacher and a wonderful researcher. She's a sought-after speaker in many of the conferences in India and abroad. And she has published 469 original articles in index journals and more than 300 abstracts, 8 chapters, and 50 research studies. And she also is known that she has made a user-friendly, free, evidence-based, peer-reviewed mobile app for managing GI and liver emergencies. She's going to talk on Helicobacter pylori and how to manage. And this is a very important thing, because Helicobacter pylori is known to be associated with many diseases, especially for ulcer disease and even malignancy. And there is a lot of concern about whether we should treat dyspepsia with H. pylori or not. So Dr. Usha Dutta has a very large experience in this field of H. pylori. And may I request Dr. Usha to start her lecture. Dr. Usha, please.
Thank you so much, Dr. Philip Mathew, for a very extensive and a very kind introduction. I really appreciate. Dr. Philip Mathew is a very prominent person in the scenario of the Indian Society of Gastroenterology and has been actively contributing to various aspects of it. It's just wonderful to have you on board today, sir. Thank you. I'll keep the lecture very simple so that everybody can benefit from it. It is more directed at how it will change clinical management for the patient with H. pylori who comes to you next. So H. pylori is actually an old hardy bug, and we have 50,000 years of association with the human gut. Mummies in Egypt have H. pylori in them, and over 50% of the world population is infected, more so in countries which are still developing, like India. So it enters the body without too much of fanfare. H. pylori releases a urease enzyme. It increases the local pH, which degels this mucin. And then it enters into the mucin and crosses the mucin with its flagella and colonizes under the mucus layer and incites inflammation and just survives on the cellular exudates. So it's a very happy commensal organism, but it is not a symbiotic relationship. So the onset is usually insidious. So that's why many people do not know they are harboring H. pylori. What's new about this old bug? Several consensus meetings have very clearly underlined the fact that whenever you see H. pylori, you should treat it because it is a class 1 carcinogen. So all H. pylori needs treatment, even if it is asymptomatic infection. And the resistance pattern is increasing. So these are the two new things of H. pylori. So all H. pylori needs treatment, even if it is asymptomatic, and the resistance pattern is increasing. So we need to know how to manage it. It hides from our immune system. So it's under the mucus layer, and you can see it has its various antigenic properties. And here it stays here and causes inflammation and also causes mutation. That is why it is a bug which can cause cancer as well as chronic inflammation in the gut. So patients may be asymptomatic, but within the gut, there is chronic inflammation going on. So there is nothing like normal person with an H. pylori. If there is H. pylori, there is inflammation. And if there is inflammation, chronic inflammation, there can be cancer. So antral gastritis, gastric atrophy, high acid state may have an ulcer. Patient may come to you with bleeding or pain. And in a low acid state, the patient will have a malignancy like a CA stomach, maltoma, as well as lymphoma. So we have to treat H. pylori to prevent all these states because it's a WHO class 1 carcinogen. In a study in Taiwan, they showed that if there was mass eradication of H. pylori, there was a steady decrease in the gastric cancer rates. So here they found that over years, there was 53% reduction in gastric cancer from 2004 to 2016, indicating that eradicating H. pylori, apart from trying to improve the symptoms and prevent various disease manifestations, it can reduce the cancer. So to treat or not to treat was a big question because when we were students, we were told that H. pylori is there. It has been there with human beings. You don't need to treat because treating is not going to always improve symptoms. So there's no need to treat. However, things have changed. The risks of not treating is cost, logistics, resistance, reinfection, and recrudescence. But there are lots of benefits. It decreases symptoms, it decreases cancer, it decreases ulcer, decreases bleeding, and decreases iron deficiency. So the consensus is to treat. Issues are whom to test, how to test, whom to treat, how to treat, and how to test for eradication. To whom to test? Anybody you're doing an endoscopy and you find antral gastritis, please test for H. pylori by doing a rapid urease test. If there is extensive gastric atrophy, you know H. pylori could be an initiator. Please do an H. pylori testing to ensure that this patient doesn't go on to develop early gastric cancer. If there's an ulcer and the patient has come to you with bleeding or symptoms, treat for H. pylori. It will help in treating the ulcer as well as preventing complications due to ulcer. All of you must have seen that during our undergraduate days or 30 years back, we used to find patients with gastric outlet obstruction due to ulcer disease. But now we hardly see it because many patients have received antibiotics. H. pylori has got eradicated or suppressed, and we don't see so much of active ulceration during endoscopy. And you can also prevent CA stomach. To whom to test? Patients with iron deficiency anemia, B12 deficiency, unexplained B12 deficiency, ITP, family history of gastric cancer, patients on NSAIDs, patients on anticoagulants, all of these patients need to be tested for H. pylori so that they don't have risk of GI bleed later on when they are on chronic NSAIDs or on anticoagulants. So this is especially important in patients with cardiac disease when they are going to go on double antiplatelet agents. It's a good idea that if they need endoscopy for anything, or they can be tested for H. pylori, because it's very common for a patient to be admitted in the cardiac intensive care unit and have a GI bleed, and then we are rushing to see such a patient to manage them endoscopically. So in the OPD, if you're sitting and seeing a patient of dyspepsia, before you call it functional dyspepsia, please exclude H. pylori. This is according to the latest Rome 4 recommendations. And before you start empirical PPI for dyspepsia, again test for H. pylori before you just start these patients on PPI. If the patient has an indication for endoscopy, then endoscopy and rapid urease test. If the patient doesn't have indication for endoscopy, you can do a stool antigen test, which I have found very useful in these patients, or a breath hydrogen test to pick up for H. pylori. So how do we diagnose? If the patient is not going for endoscopy, use a stool antigen or a breath test. If the patient is going for endoscopy, a rapid urease test and a histopathological examination to look for H. pylori. If you're doing a community study or a prevalence study, serology is be worthwhile. So the urea breath test, the stool antigen test, the serology, rapid urease test, and histology all have decent sensitivity of about 90-95% and a good specificity of 90-98%. So there's little to choose from this. So all that I would say here is the stool antigen test is a very useful test in these patients. If patients have a problem giving a stool test, a urea breath test is another useful hospital-based test. Culture is useful only in patients where we are suspecting resistance. The important caveat to realize is that the rapid urease test, the stool antigen, and the urea breath test are dependent on the H. pylori load. So if the patient has recently received antibiotics, proton pump inhibitors, or has had a GI bleed, you may get a false negative test. So a negative test will not exclude H. pylori if the patient is already on PPI and antibiotics. This is a very common problem in our outpatient setup. Serology and stool antigen need validation of strains, and culture needs a good lab with anaerobic culture, and RUT and histology need endoscopy. So this is how a urease test looks. We put a biopsy into this yellow gel, and it turns into pink if there's H. pylori positive, because this is a pH change, and you can have various types of such kind of tests. Most important to remember, the room temperature should also be 25 degrees plus so as to elicit a positive reaction. Before you test for H. pylori, patient should not be on any antibiotic and not on any proton pump inhibitors. And then you can do any of the tests, and if it is positive, as I said, we should treat it. Isolated serological positivity is not treated unless, say, it is a moltoma or a CA stomach, where other tests are coming negative and your high index of suspicion of H. pylori, then you can treat or based on serology. How to treat? Which drug, what dose, which regime, what duration, who needs testing for resistance, and how to tailor it in India. So H. pylori treating is a challenge because the doctor is complacent, the bug is hardy, the patient is not compliant, and there is drug resistance. So we have to hit hard until it is gone. So what are the drugs we have? These are the 4 common drugs: proton pump inhibitors, metronidazole, clarithromycin, and amoxicillin. So this is the mainstay of therapy. Apart from that, we have drugs like quinolones, rifabutin, bismuth, and probiotics whenever we are having problems with these 4 drugs. So the proton pump inhibitors has multiple mechanisms of action, and it is actually the cornerstone of therapy. It is not just PPI to suppress the symptom, because PPI suppresses H. pylori and increases the efficacy of the antibiotic because it gets the pH to a high level. Then H. pylori enters into a replicative state. And when it is in the replicative state, the antibiotics can act better. Another thing is it prevents clarithromycin resistance by inhibiting the efflux pump. So we need to treat it with the best PPI in the best possible dose. So what is that? Minimum 40 milligram BD of rabeprazole, esomeprazole, or vonoprazole. And there is no role of using omeprazole or in the treatment of H. pylori, because we have now better agents to treat are H. pylori. Even pantoprazole again is not the ideal drug in such a situation. Amoxicillin is an important drug because it inhibits the cell wall synthesis of H. pylori and prevents clarithromycin resistance. Now, how much dose? Earlier, we used to use 750 milligram. Now it is 1000 milligram twice a day. And higher the dose, higher the efficacy. Clarithromycin, again used in a dose of 500 milligram twice a day. It inhibits the protein synthesis. The problem is of increasing resistance to clarithromycin. The third drug was metronidazole. However, we hardly use it in India because there's a lot of over-the-counter use of metronidazole and there's very high H. pylori resistance to metronidazole. So what are our saviors when we encounter resistant H. pylori? Quinolones, that is levofloxacin or moxifloxacin. Rifabutin is a very useful drug because it is 10 times more concentrated in the gastric juice. It's chemically stable, resistance is very low, and it's not prone to resistance on use. So rifabutin is an important second or a third line agent in our management of H. pylori, and it should be reserved only for that. And it's used in a dose of 150 milligram BD. Bismuth, I have found this to be a very important mainstay therapy in today's day of treating H. pylori in India, where resistance is going up. The interesting thing about bismuth is it's low cost, it is efficacious, very few side effects except for dark colored stools, and it inhibits all the enzymes like urease, catalase, and lipase, and it doesn't get affected by resistance. So resistance to H. pylori is not a feature of bismuth, and hence it's a very important drug for us. So there is colloidal bismuth subcitrate, which is 120 milligram 4 times a day. So this is the only problem I have when I'm prescribing bismuth. I have to tell the patient to take 120 milligram 4 times a day. And the clinicians hesitate because they think that there may be compliance issues. Patients have black stools. Pharma companies find it a low cost, low profit thing. So there hasn't been so much of enthusiasm about bismuth, but now bismuth is now freely available in India as well. It's available over the counter in the West. And this is a useful drug which can be safely given in H. pylori treatment. I'm sorry about my throat. Probiotics may have some role in as an adjunct to the management of H. pylori, but it's not the mainstay. Isolated probiotics have no role. In difficult to treat H. pylori, probiotics can be added, preferably at the end of therapy, to help them regain their flora. And during the therapy, especially if you're suspecting difficult to treat H. pylori. The important thing about probiotic is it helps in destroying the biofilms. So H. pylori resistance, there is biofilm. Within the biofilm, the H. pylori stays, and that is not accessed by the antibiotic, and this helps in destroying the biofilm. So which regime, what duration? This is the most important slide of this talk. Standard triple therapy has proton pump inhibitor, amoxicillin, and clarithromycin for the first week, and again the same 3 drugs for the second week. I will not go into each of these therapies, just that I will tell you that if you want with this, you can just add bismuth. Proton pump inhibitor, amoxicillin, clarithromycin, and bismuth makes for 2 weeks is a good concomitant regime which can help you eradicate H. pylori in your patients. There are several other modifications. I will not go into it because the simplest regime is to give either 3 drugs, that is proton pump inhibitor, amoxicillin, clarithromycin, or give proton pump inhibitor, amoxicillin, clarithromycin, and bismuth if you suspect you're in a high resistance area. So I don't want to confuse you with various things, but here is a treatment which tells you which one is better. This chart tells you which one is better. The vonoprazan based triple therapy is ideal if you can get it in your own system. In India, vonoprazan is just being introduced, and the next best which we have is, as I said, a 4 drug regime. Quadruple therapy is better than triple. Bismuth is better than non-bismuth. Clarithromycin is better than non-clarithromycin. And vonoprazan is better than no vonoprazan. 14-day therapy is what is important. Earlier, there were lots of studies of 7 days versus 10 days versus 14 days. But the consensus and the meta-analysis suggests 14-day therapy. So what does the guideline say? Guideline says if it is low clarithromycin, use PPI, amoxicillin, clarithromycin. If there is high resistance, use PPI, amoxicillin, clarithromycin, bismuth. And dual resistance, again, both of these 4 drugs. So this is what we need to remember, 3 drugs or 4 drugs. In India, we do not use metronidazole, so we have to choose between this regime or the PACB regime. So what are the factors which affect efficacy? 14-day therapy has better efficacy. Newer generation PPI, better efficacy. High dose amoxicillin, better efficacy. Adding bismuth, better efficacy. Adding probiotic, some limited data to suggest some benefit. If the patient is smoking, please ask them to stop smoking. If there's poor compliance, should be avoided. If the patient is obese, they have less chances of eradication and certain CYP polymorphism. So what can you do to improve efficacy? You can add bismuth, it improves efficacy by 10%. You can add probiotic, it improves efficacy by 13%. You can add probiotics to this 4-drug regime to improve it by 11%. You can replace clarithromycin with quinolones to increase efficacy by 10%, and you can replace PPI with vonoprazan to increase efficacy by 13%. So making these modifications will increase our eradication rate in these patients. So addition of bismuth, there's a recent European registry on H. pylori, which has shown that at real life, there is increase in efficacy, and a 14-day regime has a 92% efficacy compared to 79% for the 10-day regime. So they were mild reactions, but most of them were very mild and transient, and none of them caused stoppage of therapy. So addition of Lactobacillus reuteri also had improved efficacy to 96% from 98%. Resistance in Asia Pacific region is rising. The red line shows the metronidazole resistance, which is high, 45% in the Asia Pacific. In India, it's already 80%. And you can see that the levoflox resistance is also going up. And we are having clarithromycin resistance is also going up to about 21%. And we will show you that in India, it used to be about 17%. And now latest study, which we have done, shows a higher clarithromycin resistance. So there's a study from Bhubaneswar, which has shown that clarithromycin resistance is about 34%, amox resistance 3%, and levoflox about 65%, and metronidazole 81%. So we did a recent study on uninvestigated dyspepsia in about 11,000 patients, 1,100 patients. Organic dyspepsia was in 424 patients. That means they had an ulcer or a growth, or they had 31 polyps and antral gastritis in 160. The rest had normal endoscopy. And 424 had organic dyspepsia, 762 had functional dyspepsia, and out of these, we found 374 had H. pylori. So that means 30% of our uninvestigated dyspepsia are having H. pylori, so it's worthwhile to test it and eradicate it. And we studied their rapid urease test, and those who were rapid urease tests, we also went ahead and looked at their LAMP PCR. LAMP PCR is a very short 1-hour test to pick up H. pylori using molecular methods. And interestingly, we found that among those who were H. pylori RUT negative, some patients were also LAMP PCR positive. That means LAMP PCR picked up additional 15% patients who were missed by RUT. So these were patients who were maybe having low level of H. pylori. So the LAMP PCR gives us results like this. And within 1 hour, if we test, we can pick up H. pylori resistance to clarithromycin, presence of H. pylori, as well as the resistance pattern. So what did we find? We found 35% of our patients were having resistance to H. pylori. So what is the approach to treatment? If you're in a low clarithromycin resistance area and the patient does not have a history of antibiotic and it's a first time treatment, use the standard triple regime. That is PPI, amoxicillin, clarithromycin, 14 days. No confusion. If this patient actually comes back with failure, then we try bismuth quadruple therapy, that is PPI, amoxicillin, clarithromycin, bismuth. We also use this as first line if the patient is already in a high clarithromycin resistance area or the patient has received antibiotic recently for a respiratory issue. If this fails, we use levofloxacin. So we replace the clarithromycin with levo. And if that fails, we use rifabutin triple therapy, that is PPI, amoxicillin, rifabutin, if we are suspecting multi-drug resistance. So I let the slide stay for a minute just to reabsorb the important thing. First time treatment, just 3 drugs, PPI, amoxicillin, clarithromycin, 14 days. If that fails, you add bismuth. If that fails, you add levoflox. If that fails, you use rifabutin. So that is the way to go. Most important, after you have treated, keep the patient off antibiotic and off PPI for minimum 2 to 4 weeks, and then repeat the stool antigen or a urea breath test to say that the H. pylori has got eradicated. Because unless you test for eradication, when the patient comes back with symptoms, you do not know whether the patient was completely treated at that point or not. You do an upper GI endoscopy if the patient had a gastric ulcer, because gastric ulcer may be actually a CA stomach masquerading as a gastric ulcer. Please do an endoscopy if the patient had a gastric ulcer and H. pylori. So the Indian perspective is the actual real life eradication is about 80 to 86%. So that is why I advocate that we add bismuth in the first level itself, and resistance to these drugs are rising. So bismuth is a safe drug to add. So the take home message is treat if you find H. pylori, even if the patient is asymptomatic. If you're doing an endoscopy and you're finding antral gastritis, don't just take the scope out. Minimum take biopsies in the antrum and one from the fundus, put it into one vial for RUT assessment, and if it is positive, treat. Use only standard combination of the standard doses: amoxicillin 1 gram BD, clarithromycin 500 BD, PPI 40 BD. Ensure compliance. Tell the patient that there is a difficult bug in your stomach, and to take it out, we need all these medications for 14 days. Many patients don't know why they're taking so many drugs and they miss out 1 or 2, and they then do not have good compliance to eradicate. And tell the patient that this is just a 14-day therapy and they should just take it. And if they are not able to take for some reason, they should report back to you. Many times patient will come back after 14 days and say that, no, I could not take this in between, I could not take that, and that doesn't help. So check for eradication always, and testing for resistance in selected situations. Choose a high dose PPI, choose new generation PPI like esomeprazole or rabiprazole. Choose a higher dose amoxicillin, 1 gram or 2 gram BD. Add bismuth, 120 milligram 4 times a day. Replace clarithromycin with levo if you think there is resistance. Do not use metronidazole. Consider rifabutin if resistance is suspected. Thank you.
Thank you, Professor Usha, for this wonderful talk. May I request Sunil also to join? There are
I'm already there, Dr. Mathew.
There are some questions. Sunil, can you take up those questions?
Yeah. So someone has asked, Doctor, what is the role of doxycycline and tetracycline in quadruple therapy, PPI plus tetracycline and levofloxacin?
Yeah, very important. We used to use a lot of tetracycline earlier on, but nowadays it has gone to vogue. But now again, tetracycline resistance is dropping. So it may be a drug which may be coming back for use. There are more studies on tetra rather than doxy, but both of them can be used in such a situation. The interesting thing about rifabutin, which we can use it as third line, is that it gets concentrated in the mucus layer. Tetracycline and doxycycline do not have the same level of efficacy, but I think with resistance to other drugs coming, it may be a salvage drug again for us.
And Dr. Usha, tetracycline is still available? I think it is off market. Doxy is commonly available.
Yeah, doxy is available. Tetra is nowadays not available because of teeth issues and all those things.
Yes.
Now, Dr. Usha, if you are using doxycycline, the dosage is same, or you want to give only 100 milligram twice daily? How is the doxycycline replacing tetracycline?
Sir, frankly, I don't know because I don't use it, but I can check and message it. I'm sorry.
It's okay. And another thing, Usha, we come across upper GI bleed, and in that, you know that H. pylori can be falsely negative. So, is there any? What is your policy? What do you address? Do you treat all these patients irrespective of whether H. pylori is positive or negative? You empirically treat this patient of upper GI bleed with ulcer bleed. I'm talking about ulcer bleed. Will you treat everyone with H. pylori eradication regime?
So what I do is when a patient is having GI bleed, I would check whether the patient is on NSAIDs or ecosprin. If there is no NSAID, no ecosprin, the probability of H. pylori becomes even higher. Even in the presence of NSAID and ecosprin, there could be H. pylori. Quite often, if the patient is bleeding and stable and has stopped bleeding during the endoscopy, then I have time to take a biopsy from the fundus and put it into RUT, or take a biopsy from the fundus and send it for histopath. Histopath takes a long time, so I would like to put it into the RUT from the fundus. If the patient is having ongoing bleeding, then and the patient is not particularly on PPI or something, then very high chance of it being H. pylori. And studies have shown that if you eradicate H. pylori, the chance of rebleed decreases. So in such a situation, difficult ulcers, I may empirically also treat for H. pylori. That would be the best option at that time because all other tests may be false negative during active bleed.
So,
Okay. Dr.
asked,
Seetal Karnawat has asked, why can't we use serology for diagnosis?
Yes, very important. Serology is useful to tell you past or present infection. Now, in a country where we have very high exposure to H. pylori, like in India, serology may be falsely positive, may indicate past infection, may not indicate ongoing present infection. Whereas in countries in the West and in other places where there's better chance of good hygiene, then serology is more useful in that setup. And there, if serology is positive, I think we can still treat these patients. But in India, we try to look for things which tell us active infection like stool H. pylori antigen, RUT, or breath test, or histopathology.
Yes.
Usha,
And Dr. Piyush Manoria has asked, which part of stomach should you take RUT?
Yeah, very important question. Usually, we used to advocate antral biopsy for RUT, but of late, I find that a large number of patients invariably have taken PPI and the H. pylori has migrated to the fundus. So what I do is I take a biopsy from the antrum and one biopsy from the fundus, put both of them into the RUT gel and ensure that the RUT gel is put in an incubator so that the temperatures are maintained to get you a better reaction with RUT. And there are lots of RUTs in the market. Very few are nicely validated kits. So ensure that your RUT is of good quality.
And how much time do you wait for till the positive result comes?
Yeah, so immediate reporting is at 30 minutes. And if it is negative at that time, it should be incubated till the next day morning. And at 24 hours, it is declared negative. So first reporting at half an hour and the second reporting at 1 day. If you can't, if the patient has come from a faraway place, he's intelligent, you can even ask him to take it home and send you a pic on the mobile to show you the RUT 24 hours later. If you have your own lab, you can keep it and ask somebody to report it at 24 hours.
So it can be kept in the room temperature or should be kept at some warmer place?
The problem is endoscopy labs are in generally very cold. So RUT is a problem in endoscopy labs. So I just shifted to our routine lab, which is at better room temperature. So something like 25 degrees is perfectly fine.
Okay.
There is
Another question from Dr. K.S. Yadav is, if someone develops diarrhea with amoxicillin high dose, what should we do?
Yeah, so whenever I tell the patients that if they are taking the medicines and they develop diarrhea, they come back to us, and then I remove the amox and I can add, say, levoflox or something, because then the patient is continuing on clarithromycin, levoflox, and bismuth.
Okay.
Or
Dr.
we
Mathew,
can
please.
take probiotic, but many patients who start developing diarrhea, then they find it difficult to take. So we can withdraw amox and put levo, or we can add probiotics.
So we can have only 2 minutes more. I think, Subin has asked a question. Subin, why don't you just ask question directly? Dr. Subin?
Yes, yeah. So, ma'am, usually, what I see in the practice is that we diagnose H. pylori, we treat it, but after a year or so, the reinfection rates are quite high. So, where do we draw the line that we keep on treating them because it's a grade A pathogen now by this thing WHO. So, where do we draw the line? When do we say we will not treat you?
Yeah, so very important and practical question. Quite often it is not reinfection. Earlier on in India, we used to keep thinking it was reinfection. But I think with improving standards of hygiene, the chance of reinfection is going down. It is quite often just a suppressed H. pylori which has come back again. That with the previous antibiotic, it became negative. Maybe it was a very low level H. pylori, it has come back again. So second thing is, if you see H. pylori, you have to treat. I don't think you have an option of not treating just because you tried treating once.
So, so it is a recrudescence rather than a reinfections, that is right. And there is another question by Dr. Ragesh. Can we start levofloxacin based triple therapy in place of clarithromycin because of resistance of clarithromycin is increasing?
Yes, we can try levofloxacin. Most of our pulmonologists don't like us using levofloxacin, but I think that is an important drug from gastroenterologist perspective. So levoflox can substitute clarithromycin if we are suspecting resistance. So if a patient has had a recent chest infection, has received azithromycin, I would give upfront levoflox rather than clarithromycin.
Dr. Nishal has asked a question after eradication, again, if you find H. pylori tested to be positive, how you treat? I think you have to go for another regime. Am I right?
Yes, you have to ensure that the previous regime was complied with properly and it was taken for 14 days. And despite that, if there's a problem, suspect resistance, and then you can make a change in the drug or you can add a bismuth to that.
And I think the last question, there are more questions coming up, is we have no time. In gastric maltoma, what is the duration of H. pylori eradication therapy?
In gastric maltoma, you want to be sure that you have eradicated. So minimum 2 weeks of therapy. And I would like to give bismuth for another 2 weeks. So total of 4 weeks of bismuth. And definitely testing for eradication is important. Very interestingly, I studied a patient of lymphoma and the patient was not responding to the radiotherapy. But after giving H. pylori eradication, the radio sensitivity improved of the tumor. So you have to take out the antigenic stimulus very well to prevent that further stimulation of the lymphomatous cells.
There is a very interesting question by Benjamin. How many times one can treat H. pylori a particular patient? It's nobody can answer.
Yeah, I would say if your last regime should minimum be the best one you can give, and that would be maybe rifabutin based therapy. I would give rifabutin, bismuth, amoxicillin, and PPI, and minimum for 2 weeks. We can even extend it for 3 weeks if you think it is a very difficult bug, and I think we should give it the best shot.
So I think we had a wonderful session, Professor Usha. It was we have actually the quality of a teacher depends upon how she can or he can take a class for the highly qualified people as well as baseline general practitioners as well as physicians who are aspiring to learn more and more and seeing a wide spectrum of patients. We know as gastroenterologists, we are a specialty of medicine, focusing only certain areas. Physicians look at patients in a wider angle, and they are knowledgeable better than a specialist in or if you put all aspects put together. So thank you so much, and Dr. Usha, Dr. Zubin, and Dr. Dadhich for this wonderful.
Yeah. I think Dr. Mathew, I think we can invite Dr. Sushil Jain for giving the vote of thanks.
Yeah,
Sushil
thank
Jain
you.
from GAPIO.
Thank you, Dr.
Yes.
Zubin. Yeah, thank you. Really wonderful and enlightening session. Both the topics very well said and very understandable terms. The algorithms presented by Dr. Zubin and the treatment regime by Dr. Usha, amazing. So I take this opportunity to thank all of you, Dr. Zubin, Dr. Usha, Dr. Sunil, and Dr. Mathew Philip, for attending, for presenting in this session and helping us to learn more about these two topics. I also like to thank the GAPIO team behind Mr. Jitin Malik and the IT team for organizing this session. And we look forward for further sessions like this. Thank you, everyone, and have a nice weekend. Thank you.
Yeah. Thank you.
Thank you.
Thank you very much.
Thank you all. Thank you so much.
Thank you.
Thank you.
Good night.